Welcome everyone. Welcome to what many medical students consider the Mount Everest of clinical medicine, the central nervous system examination. Today we are not going to climb the entire mountain in one breath. Instead, we are looking at the map. Think of this presentation as your GPS or clinical proforma. I am going to show you exactly what steps we take from head to toe to unlock the secrets of the human brain and spinal cord. We won't dive into the exhaustive mechanics of every single reflex today. That's what our upcoming lectures are for. Today is about mastering the flow, the structure, and the sequence. Let's map the matrix. Before you touch a patient, you need a system. Our CNS proforma is broken down into 13 distinct pillars, ranging from basic demographics to complex motor, sensory, and autonomic checks. If you memorize this order, you will never feel lost at the bedside. Let's start with step number 1. Slide 3 brings us to pillar 1, handedness. We always document whether a patient is right or left-handed. The question is why? Because this gives us an immediate clue about cerebral dominance, especially when interpreting speech deficits. It's a simple question that completely recalibrates how you interpret cortical signs. We will learn the exact cortical percentages in our later hemisphere lectures. Pillar 2 is education. You must document the patient's educational background. Again, the question why? Because it defines your baseline for the cognitive assessment that follows. You cannot accurately test calculations or abstract reasoning without knowing their baseline education level. It protects you from misinterpreting a lack of schooling as a neurological deficit. Now we enter pillar 3, higher mental functions. We always begin with consciousness. If it's impaired, we don't guess. We objectively document it using the Glasgow Coma Scale or the GCS. In our next presentation, we will dedicate an entire hour to mastering GCS scoring perfectly. But for now, remember, consciousness is always your starting gate. Next, within higher mental functions, we check orientation to time, place, and person. Followed immediately by memory, which we split into 3 distinct buckets. Immediate repetition within 30 seconds, recent recall up to 5 minutes, and remote memory for events further back. This sequence tells you exactly which circuit of the brain might be struggling. We then assess global intelligence, that is the patient's emotional mood state and concentration via calculation tests like asking them to subtract 7 from 100 serially. It sounds simple, but it demands an intact frontal and parietal lobe. We will look at the specific tracking sheets for these in our cognitive deep dive. Next is speech. Speech is a window into the dominant cortex. In this section of the proforma, we evaluate comprehension and fluency or word output. You need to ask questions like, can they understand you? Can they produce words smoothly? This is where we lay the groundwork to differentiate motor and sensory speech pathways. To wrap up the speech profile, we test repetition, reading, writing, and naming objects while closely listening to phonation. This allows us to document the precise presence of an aphasia or a dysarthria. Don't panic about memorizing Broca's versus Wernicke's today. Just remember that these are the required steps to uncover them. We conclude higher mental functions by noting the presence or absence of apraxia, that is the inability to perform learned movements, and agnosia. We check for hemi-neglect and document any hallucinations or delusions. This signify major cortical or psychiatric disruptions, which we will analyze case by case later. Moving to pillar 4, the cranial nerves. We test them symmetrically, right versus left. We start with cranial nerve 1, the olfactory nerve. You will check the sense of smell using non-irritating familiar scents like soap, coffee, or lemon peel, checking one nostril at a time with eyes shut. We note if they can appreciate the smell and if they can identify it. Cranial nerve 2 is the optic nerve, and its proforma contains 4 steps. Visual acuity using Snell's or Hager's charts, visual fields via the confrontation method or Mine's reflex, color vision with Ishihara plates, and finally direct visualization via fundoscopy. This is a structural protocol for the visual pathway. Next, we group cranial nerves 3, 4 and 6 together because they control eye movement. First, inspect the eyelids for ptosis and look at the resting position of the eyeballs. Then, test extraocular movements, checking both binocular movements including saccadic, pursuit and reflexes like doll's eyes, and uniocular movements to screen for ophthalmoplegia. Still within the ocular trio, we measure the pupil size in millimeters, their shape and their reactions including direct light, consensual and accommodation reflexes. We also check for nystagmus, describing whether it is spontaneous or provoked and its direction. This tells us immense amounts about the brainstem, which we will map in our upcoming neuro-ophthalmology module. Now this slide brings us to the cranial nerve 5, the trigeminal nerve. Sensation is checked across all 3 divisions, forehead, cheek and jawline, for touch, pain and temperature. For the motor component, look for jaw deviation, muscle wasting and teeth clenching. We finish with the corneal reflex and the jaw jerk. We will practice this exact sensory boundaries in our next practical session. Cranial nerve 7 is the facial nerve. We inspect for asymmetry, then test the muscles of facial expression by raising eyebrows, shutting eyes tight, smiling and whistling. We look for Bell's phenomenon, check taste on the interior 2/3 of the tongue, and note lacrimation and hyperacusis. This lets you distinguish between upper and lower motor neuron facial lesions cleanly. Cranial nerve 8 is the vestibulocochlear nerve. We test basic hearing with a simple finger rub, then differentiate conductive versus sensorineural hearing loss using Riney's and Weber's tuning fork tests. For dizzy patients, the proforma includes the caloric test using warm and cold water. We will cover the acronyms and physiology of caloric nystagmus in detail in our future lectures. Nerves 9 and 10 are evaluated together. Watch the patient swallow. Listen to their voice volume. Check the position and movement of the uvula when they say ah, and elicit the gag reflex. We also check taste on the posterior 1/3 of the tongue. This checklist is your ultimate defense against missed lower bulbar palsies. We finish the cranial nerves with 11 and 12. For cranial nerve 11, test the sternocleidomastoid and trapezius muscles against resistance via head rotation and shoulder shrugging. For cranial nerve 12, – inspect the tongue inside the mouth for wasting or fasciculations. Then check for deviation upon protrusion, alongside its tone and power. And just like that, your cranial nerve screening is structurally complete. Moving right along into Pillar 5, Motor System Examination. Before we ask the patient to move a single muscle, we begin with attitude. This means observing the natural resting posture of both the upper limbs and the lower limbs. Is an arm flexed and adducted against the chest? Is a foot externally rotated? The resting posture tells us an immediate story about the underlying muscle tone imbalances before the patient even says a word. We will study what these abnormal postures look like in our next session. Next, we assess bulk. We start with inspection, looking for symmetry, generalized wasting, or small muscle wasting. We specifically check for structural deformities like a claw hand or a foot drop. Remember, your eyes are your greatest diagnostic tool here. We are looking for visible signs of asymmetric muscle loss, while we will learn to map to specific nerve lesions very soon. But we don't just rely on our eyes, we measure. This slide details our exact pro forma protocol for measuring bulk in centimeters. You must measure at a fixed, identical distance from a bony landmark on both the right and left sides. 10 centimeters above the olecranon for the arm, 10 centimeters below it for the forearm, 18 centimeters above the patella for the thigh, and 10 centimeters below the tibial tuberosity for the leg. This step ensures your data is completely objective, leaving no room for guesswork. Now we move to tone. During a physical exam, you will passively move the joints of both the upper and lower limbs on the right and left sides. Your goal here is to simply document whether the resistance is normal, decreased, that is hypotonia, or increased, that is hypertonia. And we categorize hypertonia into spasticity or rigidity. In our upcoming motor system workshop, you will feel the physical difference between the clasp knife spasticity and lead pipe rigidity firsthand. Next up is power. Here is a golden rule of the pro forma. Always fix the proximal portion of a limb when examining the movements of the distal portion. We grade power strictly using the Medical Research Council scale from 0 to 5. Grade 0 means complete paralysis. Grade 1 is a mere flicker of contraction. Grade 2 means power is detectable only when gravity is eliminated. Grade 3 means they can overcome gravity. Grade 4 means gravity plus some resistance. And grade 5 is normal power. Memorize this scale. It will be your daily bread on the wards. Now let's look at the specific muscle groups we check starting from the top. For the neck, we test flexors and extensors, but note the safety warning on your pro forma. Avoid active movement checking if a cervical cord injury is suspected. For the shoulder, we check abduction from 0 to 15 degrees and 15 to 90 degrees to isolate different muscles alongside adduction, flexion, and extension. This sequence guarantees you screen every major spinal segment supplying the shoulder girdle. Moving down the arm, our checklist requires testing the elbow for flexion and extension, the wrist for flexion and extension, the overall hand grip utilizing long flexures, and finally the small muscles of the hand. We check both the right and left sides meticulously. This step-by-step approach lets you differentiate between a localized peripheral nerve injury, like a radial nerve slip palsy, and a central brain injury. Don't ignore the core. We test the trunk muscles by asking the patient to elevate their head or leg while lying supine. We watch for Beaver's sign and we look for signs of respiratory muscle weakness, such as abdominal breathing with epigastric bulging or an inability to sniff. These signs tell us if the intercostal muscles or the diaphragm are failing, which can be a medical emergency. Moving to the lower limbs, we test the hip for flexion, extension, abduction, and adduction, isolating muscles like the iliopsoas and the gluteals. Then we test the knee for flexion via the hamstrings and extension via the quadriceps. Keeping this rigid right versus left sequence ensures you never accidentally skip a major joint compartment during a busy clinical exam. We finish our muscle power checklist at the ground level, that is the ankle. We test plantar flexion by having them stand on their tiptoes, dorsiflexion by having them stand on their heels alongside inversion and eversion. If clinically indicated, we finish with the small muscles of the foot and the extensor hallucis longus. And with that, your complete motor power screening sheet is fully executed. Now we enter pillar 6, reflexes. We always divide this into categories, starting with the superficial reflexes. Your performer contains the corneal reflex, the abdominal reflexes split across epigastric, mid-abdominal and hypogastric segments, the cremasteric reflex and the anal reflex. In our future sessions, we will look at exactly how these pathways rely on both a functioning peripheral arc and cortical modulation. The king of superficial reflexes is the plantar reflex. This slide lists its exact reflexogenic zone, its efferent and spinal cord segments. Here, you see the classic structural variants you look for if the plantar response is ambiguous, such as Chaddock's, Gordon's, and Oppenheim's sign. We will practice the exact physical path your key or reflex hammer handle should take across the foot in our next session. Next are the deep tendon reflexes. Your checklist outlines the precise spinal cord segments for each jerk, the jaw jerk in the mid-pons, the biceps and brachioradialis at C5, C6, the triceps at C6 to C8, the knee jerk at L2, L4, and the ankle jerk at L5, S2. This is a beautifully localized map. A missing reflex tells you exactly which segment of the spinal cord is under threat. How do we grade these deep tendon reflexes? We use a universal 0 to 4 plus convention. 0 means no response. 2 plus is your normal brisk response. And 4 plus is a hyperactive response that elicits a repeating reflex known as clonus. The proforma reminds us to test for patellar and ankle clonus and gives us a crucial reminder: always perform reinforcement maneuvers before declaring a reflex completely absent. We also look for latent reflexes like Hoffman's sign or Wartenberg's sign, which point towards upper motor neuron lesions. If we are evaluating a patient for frontal lobe disease or dementia, we check for primitive reflexes including the glabellar tap, palmomental, sucking, rooting, snout, and grasp reflexes. These are signs we expect to see in infants, but their reappearance in adults signals a loss of cortical inhibition. To close out this section, we observe the patient for any involuntary movements. Following that, we test coordination. Coordination bridges our transition into evaluating the sensory and cerebellar networks, which we are going to explore next. Welcome to Pillar 7, that is the sensory system. We always test primary sensation first. This includes touch, pain, temperature, vibration, and joint position sense across the right and left sides. Your primary objective here is to determine if there is a distinct sensory level or a specific pattern of sensory loss, such as a dissociative loss or a hemi-loss. We will learn how to map these pathways to the spinothalamic tracts and dorsal columns later. If primary sensation is fully intact, you can move on to testing cortical sensation. This includes tactile localization, 2-point discrimination, stereognosis, graphesthesia, and checking for sensory extinction. We round out this pillar with Romberg's test. Remember this for your exams. Romberg's is a test of sensory proprioception, not a cerebellar test. We will break down why this distinction matters in our upcoming lectures. Let's look at Pillar 8, that is the cerebellar signs, starting with the upper extremity. To check for limb ataxia, your list contains the outstretched arm test, the finger-nose test, the nose-finger-nose test, and the finger-finger test. We also check rapid alternating movements via hand tapping, pronation supination, and thigh slapping to look for dysdiadochokinesia. Still in the upper limb, we check for pointing and past pointing, observe their writing for macrographia, and test for the rebound phenomenon and intention tremors. Don't forget the lower limbs when testing the cerebellum. Our proforma checklist features the classic heel-knee test, observing for a pendular knee jerk, checking the finger-toe test, and evaluating rapid alternating movements via foot tapping. These tests allow you to determine if a cerebellar lesion is localized to one side or affecting the midline system. For general signs, we look at global indicators like titubation, a rhythmic tremor of head and trunk, alongside nystagmus, intention tremors, hypotonia, and truncal ataxia. We move to Pillar 9, that is gait. Watching a patient walk ties your entire neurological examination together. Your proforma tells you exactly what parameters to look at. Is the base wide or narrow? Is the pace slow or rapid? Are they falling to one side? Which part of the foot touches the ground first? Watch their hand swing, how they turn around, and the position of their hips. We will look at video examples of hemiplegic, Parkinsonian, and ataxic gaits in our upcoming lessons. This slide covers Pillar 10, that is signs of autonomic nervous system involvement, where we check for skin dryness, excessive sweating, postural hypotension, and a palpable bladder. Here we introduce Pillar 11, signs of meningeal irritation. You must master the physical maneuvers for checking neck stiffness, Kernick's sign, and Brudzinski's signs. These are critical emergency screenings for conditions like meningitis or subarachnoid hemorrhages. We close our primary neuroexamination steps with Pillar 12, that is the skull and the spine. looking for structural deformities, tenderness, or a short neck. Then we check pillar 13, that is the soft neurological signs, evaluating for pyramidal, cerebellar, parietal, or non-organic drifts. These subtle drifts can expose early pyramidal tract or positional weakness before it shows up on standard motor testing. As a final reminder before synthesizing your data, a neurologist is a complete physician first. Your pro forma dictates that you must always perform a targeted inspection, palpation, percussion, and auscultation of the respiratory, cardiovascular, and gastrointestinal systems. Neurological deficits are frequently secondary complications of systemic diseases such as infective endocarditis or malignancy. Once you gather all this data across the 13 pillars, you have to synthesize it into a clear case summary. Our proforma format requires you to define two things clearly: the nature of the disease based on its onset, and the precise site of involvement within the nervous system, distinguishing upper motor neuron from lower motor neuron pathways. For example, for a case of cerebrovascular accident, you must mention sudden onset, right-sided dense hemiplegia with right upper motor neuron facial palsy due to cerebrovascular accident, possible thrombotic in etiology with site of lesion being left internal capsule, possibly involving the lenticulostriate branch of middle cerebral artery. Patient is in a state of neuronal shock. You can also mention the risk factors for the patient here. Similarly, for a case of neuropathy, you have to mention acute onset of symmetrical flaccid quadriplegia, ascending, with no evidence of sensory bowel bladder involvement with bilateral lower motor neuron facial palsy, possible site of lesion in the peripheral nerve, pathology being demyelination, that is acute inflammatory demyelinating polyneuropathy, AIDP. For spinal cord disease, you can enumerate something like subacute onset of symmetrical spastic paraplegia with involvement of sensory bladder and bowel, with no involvement of cranial nerves with vertebral tenderness at T4 to T5, possible site of lesion in spinal cord, the disease being compressive myelopathy. For an extrapyramidal disease like Parkinson's disease, you can say insidious onset, slowly progressive, degenerative disease involving the motor system with no evidence of sensory, cranial nerves or bowel bladder. We would consider involvement of extrapyramidal system, probably Parkinsonism, with no evidence of secondary causes, no signs or symptoms of Parkinson plus syndromes, functional status, stage 3, Hohen and Yahr staging system. For a case of ataxia, insidious onset, slowly progressive, symmetrical ataxia, and cerebellar signs of trunk and limbs with no evidence of sensory, cranial nerve or autonomic involvement. I would like to consider the possibility of degenerative cerebellar ataxia, possibly inherited, family history positive. And that is the complete roadmap of a comprehensive CNS examination pro forma. You now have the complete clinical template in your hands. Do not worry about memorizing every single detail or nuance today. In our upcoming lectures, we will break down each of these sections with live demonstrations and case studies. For now, master this structure, embrace the clinical flow, and get ready to unlock the secrets of clinical neurology. Thank you all, and I will see you in our first deep dive session.